All right. Yeah.
So, yeah, so we are just at the top of the hour here, and I'd like to get us underway. So, welcome to the Center for Health Informatics International Alliance for Health Research and Collaboration Speaker Series. I'm Kathy Eastwood. I'm just host for this session. I'm an associate director of the Center for Health Informatics and adjunct faculty in community health sciences at the University of Calgary. So welcome everyone. And here at the Center for Health Informatics, we hope to transform data into evidence for the community. And by collaboratively working together in developing innovative health informatics and data science for precision health and precision public health. So this is a speaker series where we collaborate with our Global Affairs Department to bring together our colleagues and the work that they do in the UK and Australia. And this platform enhances the opportunities for everyone to connect with each other, share knowledge, collaborate, or potentially co-supervise students, or even travel to other locations where you may be able to learn more. So I would like to, I see we've got about 10 people online now, so that's wonderful. Today we have Dr. Kim Betts speaking for us. He's, excuse me, an applied statistician and epidemiologist working in an academic role at Curtin University School of Population Health. His research focuses on the development of behavioral and cognitive disorders in young people and the short and long-term outcomes of children undergoing cardiac surgery. I hope I've caught the overall picture there, Dr. Betts. I'll let you present, and then we'll open up the possibility for questions for about 10 to 15 minutes. And if you do have a question while he's speaking, you're welcome to put up your hand or just open your mic and you can speak to ask the question. So please welcome Dr. Kim Betts. Go ahead.
Thank you. Thanks, Catherine. Yeah, and happy for questions during the talk. So thanks for coming today. I'm going to explain a project that we've been working on. It's kind of a never-ending project, and that's a machine learning-based approach to benchmarking in post-surgical mortality, specifically in pediatric cardiac setting. Okay, so just briefly, just to introduce the disease. So we're talking about congenital heart diseases in children. So every year in Australia and New Zealand, approximately 3,000 children are born with a CHD. Half of these babies are expected to require surgical intervention at some point in their lives, and for the majority of those, it's going to be pretty shortly after birth, and then they might have repeated surgeries throughout their lifetime. But the initial surgery can happen quite quickly. Now, importantly, the diagnoses are many and varied, okay, of CHD. So they range in morphology and severity. Some are quite simple, relatively low risk and easy to fix, like ventricular septal defects, where you have a hole in the wall between the two ventricles. And some are much more severe, including hyperplastic left heart syndrome. And that's the condition that's pictured here, where the left side of the heart just hasn't developed. And essentially, the surgeon has to set up a single circulatory system in the child for them to survive. So the blood won't come back from the body to the heart, lungs, heart and body. It'll go straight from the body to the lungs, into the heart and out. So obviously, a pretty risky procedure. And then also not the best conditions for a long and healthy life. So benchmarking is pretty well understood in health and medicine now. It's done for most conditions in a lot of developed countries. But in pediatric cardiac surgery, the need for benchmarking was identified in the 80s and 90s as part of the Bristol heart scandal. So in the Bristol Royal Infirmary, and during this period, one of the intensivists was the first to notice that the babies were dying at a rate higher than he had seen in other settings where he worked. So an inquiry was launched and found that the deaths occurred due to staff shortages, lack of leadership, and all these reasons you can see listed on the slides here. A result of this, the scandal and the inquiry is that cardiac surgeons led efforts to publish more data and performance on doctors and to perform comparisons and benchmarking. And this led to an improvement in survival among this patient group across time. So benchmarking in pediatric cardiac surgery is pretty straightforward, as it is with any outcome. The basic idea is that you have a bunch of hospitals or units or perhaps surgeons in a given country or region. And for a given time frame, you just calculate the death rate or the mortality rate across the data set. You can then calculate the ratio of the hospital's observed number of deaths compared to what would be expected, which in the simple case is just the overall average. Okay, the results can be presented as a funnel plot. So most people are introduced to funnel plots through meta-analyses these days, but in statistical process control, they're very common. So they're just a scatter plot where you have the number of operations from the hospital or the surgeon on the x-axis. You have the mortality or the survival rate on the y-axis. Survival is preferred, just for obvious reasons. And then we have the survival by hospital are the dot points, and then this is referenced against the overall sample average, which is the black horizontal line in this plot. Then we have control limits, which are basically we would expect. So the 2 standard deviation alert limits is where we would expect a new hospital's survivorship to fall within 2 standard deviations. So roughly similar to 95% confidence intervals. So said differently, the blue hospital pictured there, its survival is falling within what we would expect statistically. So numerically, they have a slightly better survival than the average, but statistically, it's not really any different to what we would expect. Okay, the green hospital survival is 100%, and it's actually a bit better than we would expect statistically, whereas the purple hospital has a lower survival than would be expected by chance. It's even beyond the 3 standard deviations from the overall average. So if the data was perfect and everything else seemed to make sense, this is where you would begin an investigation into that purple hospital to try to understand the increased death rate. Okay, but that presupposes that the data has been collected correctly and everything measured properly and so on. So there's obviously a big problem with benchmarking any disease, but particularly for pediatric for congenital heart diseases in children, and that's the immense variability in the case mix. So the patient population is extremely heterogeneous. They vary by diagnoses and procedures. And as I've shown before, some of those diagnoses are extremely severe. Some are relatively mild in today's medical world. The procedures vary. The risk factors are very different, and so are the demographics. So you could have 2 babies with the same diagnosis undergoing the same procedure, but if one was born a full term, healthy birth weight, and the other one was 6 weeks preterm, you'd expect very different outcomes for those babies. So around 2 decades ago, the first attempts to solve this case mix issue during benchmarking were undertaken, and the RACS1 and Aristotle tools were developed in Europe and the United States, where basically experts, so cardiac surgeons, sat down and categorized these procedures into different risk groups. So maybe let's say that they're all a little bit different, but let's say if you had the lowest risk, you were in a group 1, the next was 2, up to the highest risk of 5. Okay, and this allowed us to carry out benchmarking within where patients were in similar risk groups. Okay, since this time, several high-quality CHD data assets have achieved maturity. So when these subjective tools were developed, obviously there was a bit of a scarcity in data among this, especially among this patient group, because CHD is fairly uncommon, compared to adult cardiac diseases, which is much more common. But since then, there is now quite a lot of data on these patients. So instead of relying on these subjective tools, we've now started building empirically based risk tools. Okay, so the difference, and I just want to point out the difference operationally quickly, is when you stratify patients by these subjective risk categories, it's quite crude, because you just have all patients with procedures considered at the lowest risk, and then the next risk, and so on. With risk adjustment, you actually build an empirical model with all the risk factors that you think are important clinically, and age, prematurity, and all the other risk factors, procedural factors. You build that model in the full data set, and this allows you to have a predicted probability of mortality in that patient. You then come back to the hospital, you apply the model to the patients within a hospital, and I've got 10 fictional patients here, and this allows you to just compare the actual number of deaths with the predicted number of deaths in that hospital. So here we've got three patients actually died, but according to the model, we would only expect 1.29 deaths. So we've seen double the deaths that we expected. So previous mortality prediction models in CHD, the first was the PRAISE, which was developed and validated in 50,000 30-day post-surgical observations in the UK. And I forgot to mention before, but the outcome specifically we're talking about is mortality within 30 days of the initial surgery. So if the patient died at 31 days, it's not included. And also the patient may have had follow-up surgeries, okay, during their hospital stay, but the clock starts from the initial surgery that brought the patient to the doctor's attention, and so that's the window, and that's standard across the UK, the US, Europe, and now Australia and New Zealand. The PRAISE model was updated in 2017, where they decided now that they wanted to include more risk factors, right? So initially they used mostly procedures and diagnostic information, then they thought we should use more risk factors. And then in 2015, the STS-CHSD developed another model using the combined North American and European data. So both models performed pretty well in the test samples, and with AUCs of 0.86, and they're both basically based on logistic regression. They used they both innovated a little bit in how they dealt with data sparsity, which I'm going to talk about in a minute, but they're essentially generalized linear models. So what about Australia and New Zealand? So the ANZCORS, the Australian and New Zealand Congenital Outcomes Registry for Surgery, this was established in 2017, mostly through the efforts and immense energies of Professor Nelson Alfonso, who's the Director of Pediatric Cardiac Surgery at Queensland Children's Hospital, which the name's changed since I used to work with him. So I've worked with him since 2016, so I helped build the case for why we need this registry. So it's nice to see it to have come along to this point now. It was initially developed to establish a comprehensive binational because it includes New Zealand, pediatric cardiac surgery outcomes registry, primarily for undertaking benchmarking of 30-day mortality, because previously the Australian hospitals would send their data to Europe and have it kind of benchmarked against the European models, which was better than nothing, but it wasn't ideal. And more than that, now it's also just becoming a very useful research tool. Okay, it was established in 2017, but it includes all data across all the centres since 2013. So we've got starting to have decent amounts of data. There's actually only 5 centres in Australia and New Zealand that perform paediatric cardiac surgery. There's one in New Zealand, Auckland, and then we have Brisbane, Melbourne, Perth, and Sydney. So the ANZCORS MRM, so in in 2023, we finally decided we had enough data to construct our own mortality risk model, the ANZCORS MRM. And I'm going light on the details here because I'm not talking about this model. I'm going to talk in more depth about the revised model, which I'm currently working on. But it achieved pretty good discrimination, again, a 0.86, similar to the other models, except we had much less data. It's published in EJACS, and I went over to the EACS conference in Milan and presented it in 2023 as well. Our approach to model development accounted for some unique strengths and limitations of the ANZCORS. So on the one hand, we have a much smaller population. We only have 5 hospitals undertaking these surgeries, and we also have fewer years of data. The other data registries begin long before 2013. On the other hand, having a smaller group of hospitals where it's pretty easy to get all the directors of pediatric cardiac surgery at the same table meant that we could sort of standardize and collect more risk factors than I believe the other registries were doing at the time anyway. I haven't kept up to date with what the other registries are doing in recent years. And we, being a newcomer, we were more open to exploring ideas like machine learning when building our mortality risk model. So I'm sort of talking about both. There's this model, and then there's the model we're working on currently, which I'll talk about for the rest of the presentation. So just to point out quickly, the main challenge in this space for all of us is probably even more the case for us in Australia because we have such a small population. But predicting mortality after surgery among CHD patients presents several difficulties, and I'm happy to be corrected, but I think of all of these as related to the issue of data sparsity. CHD is a relatively uncommon condition, impacting only 9 in every 1,000 live births, not all of which will require surgery. Right from the start, N is very low, very small. Further, 30-day post-surgical mortality rates are pretty low, thankfully, less than 2%, meaning that the effective sample size is even much smaller. So the number of children per year in the data that are actually useful for building patterns to predict mortality, it's a very small number. And then compounding this is the range of just the huge range of malformations, surgical procedures, complicating factors in this population. So we've got 213 diagnoses, 242 procedures, 45 preoperative risk factors, and 57 non-cardiac birth malformations, because malformations tend to cluster. Okay, if a child has a malformation in one system, one organ, they can have one in another, maybe even some of the common genetic malformations as well. I'm not sure malformation is the right word for genetic, but okay. So we used fairly standard machine learning approaches in the original model. So now I'm talking about the original 2023 model. We used artificial neural networks, which didn't perform well. And based on my experience and knowledge in this area, that wasn't surprising. That ANNs didn't work very well with incredibly sparse tabular data. We used elastic nets. Otherwise, in our case, this was a logistic regression with regularization. Performed pretty well, but the surgeons were not happy with the risk factors that it was spitting out as most important, because they were consistently extremely rare conditions. And it's not that there was necessarily a problem with that, but it made it sort of, if you're going to use a model to benchmark and compare hospitals, you want all the surgeons on board and happy that the model makes sense clinically. And it was just a bit strange that some of these rare conditions were so important when they were so not represented well in the data. And then gradient boosted trees, which got slightly better performance than elastic nets and produced far more clinically meaningful interpretations, as far as it is possible to interpret these very complex models. So I won't go into this slide, just here for you to look at. It's pulled from an undergraduate lecture of mine. And I can explain it in more detail at the end. But just to explain what GBTs, gradient boosted trees, are, we build So when you build a classification tree, you're essentially it's just an algorithm that splits your data, your sample, into subgroups that are more enriched for the outcome. And then we repeat this, we build multiple trees using the technique called boosting, and then aggregate these together at the end. And from what is essentially a bunch of very simple models, you end up with a fairly powerful classifier, which is, last I read, regarded as one of the most powerful classification methods for structured tabular data, as ours is here. When we came to revise the ANZCORS MRN, which I'm doing currently, we only used GBT because it was the best model in the original. It's known to perform well in structured tabular data. And we found through the first paper, it had several advantages in interpreting the model. So just some basic sort of facts of how we ran the model. So the ANZCORS data was initially separated into a development set. So all operations between 2013, 2019, or rather all 30-day windows. And this was 11,000 patients. So that's kind of the sample size we're dealing with. And then we had the external validation set, which was the 5 years of data, the most recent 5 years of data that we had at the time, that we have currently, because the data isn't available immediately. And that's done intentionally because when we do benchmarking, the idea is to build a model on the historical data and then apply it in the last 5 years of data and benchmark that, because with our sample sizes, benchmarking in a single year of data, like the latest year of data, by different procedures, we just wouldn't have the statistical power to make meaningful comparisons. So we benchmarked the last 5 years of data. The development set was randomly partitioned as is normal, 70% testing set, 30%, and the best model identified, 5-fold cross-validation. So the best fitting model comprised of 250 trees. So if you remember the trees, a tree I showed you on a few slides back, and very, very simple trees that only allowed you to split the sample 3 times. So 3 splits, and implemented some other tricks, which we can talk about later if people are interested. In the training set, AUC of 0.87, so not too much better than last time. And then in the test set, 0.86, and then the external validation set, 0.86 as well. So AUC is only one measure of performance, but it was interesting that the model was just as good at ranking patients by the outcome in the external validation set as it was in the test set. So before we used this model to risk adjust patients and then perform benchmarking, you obviously have to scrutinize the model quite a bit. So I think about it as building a model and then pulling it apart and building it again. And there's lots of ways this can be done. But 2 of the most important are to explore explainability and patient subgroup calibration, which I'll just talk about in a bit more detail. So this is just another slide pulled from an undergrad lecture, which I won't go into too much detail, but these gradient boosted trees and a lot of machine learning models are just highly complex, non-linear models and difficult to interpret. SHAP values, I'm not sure how old they are, but they're kind of the go-to method for calculating the marginal contribution of any risk factor to that individual's probability of the outcome, risk of the outcome. And then obviously if we can use the SHAP, if every individual observation or patient has a SHAP value for every single risk factor, then we can just take the average across all those patients to kind of get a global measure of risk factor influence as well. Okay. So when we did that with our model, and this is ascending, so the strongest, the most influential risk factors is actually at the bottom, and working up, this is the strongest 20 according to the mean SHAP value. So the SHAP value, again, I can go into more details, but the x-axis is the log odds scale. So if it's like they look like lines, but that's actually dot points. So that's an individual. It's not the whole sample because it would just be too hard to interpret. I probably should have applied some jitter. But basically, it's showing that if you're on the right, if an individual falls on the right-hand side of the zero, then this risk factor increased their risk of the outcome, mortality, vice versa on the left-hand side. It's also color-coded so that the feature itself, so if you look at the most influential risk factor of weight in kilograms, low weights will be yellow and high weights will be purple. So kind of what it's showing down the bottom there is there's not much purple in that line, but it does get more yellow the further to the right we move along the x-axis. So the risk of mortality is increasing with lower weights, okay? And that's not at all surprising. This would probably, we have some incredibly premature babies now. And then also, it's also a statistical artifact in that I guess, and I actually don't know this, but I assume that once you're born, if you need a surgery, you need it pretty quick. And if you're going to die, you're probably going to die pretty quick. Like once the condition's been stabilized, you know, it's probably the follow-up surgeries are probably not as serious. So if you are going to die, it's going to happen pretty quick. And that's what we see with age as well. Okay, so there's probably a few different, and that's another reason why machine learning, we don't ever think about causation with machine learning. It's certainly not the case that you'd wait for the patients to grow larger before you do the surgery or anything like that. This is purely just associations to help us understand if the model's built on patterns which make sense clinically. ECMO cannulation, so it's just, I guess for a lot of the surgeries, you know, you'll have a heart-lung machine, but ECMO cannulation is a more serious form of that, which people are pretty familiar with now since COVID. So this means that patients who were moved onto this kind of supportive care prior to the operation were already extremely sick before their procedure. And I should point out, the way benchmarking works is we only consider risk factors up until the point where the chest is open or the patient's taken into the surgery. So obviously we have lots of information about the time, how long the patient was on cross clamp, how long the surgery took, and complications which arose during surgery. None of that's included in the model because that's part of the surgery itself. We're just interested in the patient immediately before they go into the surgery. What's their risk of the outcome? Okay, because if we include surgical, like perioperative factors, then we're sort of adjusting for the quality of the surgery itself, which is what we're trying to compare. So anything you see here, like ECMO cannulation, that can obviously happen after a surgery if something's gone wrong. But this specifically refers to it taking place prior to the surgery. Then we have age, genders in there as well. I should just explain stat category 043. So the stat category is one of those stratification systems. Patients with a stat category 1 have the lowest risk operation. Up to 5 have the highest risk. Stat category 0 doesn't actually exist. This is a group of patients that the stat category doesn't apply to. So it must be miscellaneous procedures which it doesn't apply to. So these patients who are purple means they actually
have a question, Dr. Betts.
Yep.
Just whether or not female babies have a higher risk of death than male babies. Is that how that's interpreted then?
The opposite. So female gender means one would be yes, which would be female. So 0 would be yellow. So it's back to front, but I think that means male babies would have a higher risk of death.
Okay. Okay.
And I was just about to explain that. So ECMO cannulation, everybody who's purple is above 0, everybody who's yellow is below. So this means that if you had a value of 1 for ECMO cannulation, you were at a greater risk. And the same goes for stat category 0, stat category 4. Some of the operations reduce the risk, so aortic arch hyperplasia, coarctation, ASD, VSD type 2. Okay, you can see the purple, and the same goes for females. They're on the left-hand side of the 0. And stat category 2. Stat category 1's not in here, it's the reference group. And just before we move on, just interesting to note cardiomyopathy up there, which is, as far as I understand it, it's like a general, the heart is just generally unwell. It has trouble pumping blood. It's kind of weak. I'm not sure what it means exactly in children. It's a lot more common in adults than in children, but just I'm using it as an example later on. So just take note that it increased the risk of the outcome. Okay. We can also look at interactions. So they're not exactly interactions as we'd set them up as multiplicative terms in a regression model. They're just, it's basically it's a similar idea. If splitting the sample on this variable enriches the outcome so that we have a lot of cases in this group and non-cases in this group, and then another variable splits on that one, it's like an interaction in the sense that your value on one variable, the risk conferred of the outcome for your value on one variable depends on your value on another variable. So the idea is within a tree, within a single tree, so we had 250 trees, each with 3 splits, or it didn't have to have 3 splits, that was the maximum allowed. If you have variable A splitting and then variable B splitting, it suggests there's some kind of interaction between those 2 variables. So we can go through all the trees and we can pull out the interactions which occurred most frequently or had the greatest effect on separating our cases and non-cases. And if we do that, the interaction that we found the most was actually weight with itself. So in a regression, weight by weight would be like a quadratic term. Here, it just means that weight, there's some nonlinear relationship with weight, which is not really surprising because it's probably likely that there's a very high risk at low weights. And then later on, maybe there's a more complex pattern. The third one was also age with itself. So again, the model is basically, it's using these repeated trees to slowly build this nonlinear relationship of age with the outcome. We also have age and weight. And then we also have ECMO cannulation with age and with weight. Okay, so we need to investigate, and obviously in the paper, we investigate a lot of these relationships, but it's a bit boring to go through too many here. So I've just pulled out a couple. So firstly, we should investigate those nonlinear relationships between age and weight. And these are like the very few non-binary predictors in the data. So there wasn't going to be much else to look at as far as sort of nonlinear relationships with all those other 0-1 variables. So weight and age both found to have nonlinear relationships, which you can pull out with a partial dependence plot. So PDPs are a method of visualizing relationships between one or more predicted with outcome, kind of, and you can imagine with all the other variables held constant. So it's kind of, again, like the marginal risk at whatever age or weight on the probability of the outcome. Okay. Obviously, it's not a perfect representation. You can't perfectly represent these complex models, but it gives you a rough idea, and makes people, at least you can see if the model is behaving sensibly or if it's completely found something very strange. So the PDPs here show exactly what we'd expect to find, which is a very high risk at the lowest age and weight, which I said is partly due to just artifact of that's when you have your first surgery. And that's when you're at the greatest risk of the outcome. So the next thing to do is just to explore that other interaction between age and weight and ECMO cannulation. And we do this by building a type, kind of a PDP plot, where actually all we do is we take, and there's a mislabeling here, the y-axis on the top plot should be Schadt value for weight. So it's the variable by its own SHAP value. Okay, so we just, on the x-axis is just the weight or the age, and on the y-axis is the SHAP value. And we have each patient is represented as a dot point. It's just a scatter plot. But then we color code these by eCIMO cannulation, yes or no. And what you can see, it's not that clear for weight because a lot of the blue points are hidden under the red ones. But to me, it appears that eCIMO cannulation, the risk of eCIMO cannulation, the risk of mortality conferred by eCIMO cannulation appears to grow with age. Okay, so it's not such a risk factor at a younger age, but it is at a later age. And the surgeons that have seen this seem to think that made sense, or at least did not make sense. So that's obviously I'll go into a lot more detail in the paper as far as model explainability, but that's where I'll leave it today. The last thing I want to talk about, and then we're pretty much at the end of this, is calibration and the role that plays as well. So so we have to assess subgroup calibration, and I'll make it clear what subgroup calibration is in a minute. But before we assess subgroup calibration, we need to decide if the model would benefit from recalibration. Okay, so the simplest type of calibration is Platt rescaling, but there's other methods now as well. So the classic calibration plot, and we need to test the calibration in the test set. It doesn't make sense to test it in the development set because we don't know what's going on in the development set. We wouldn't expect the model to necessarily be well calibrated because the patients could be a bit different, right? Because time has passed, and the risk of death might have changed. We would expect it to improve, but it can also worsen in some cases because patients that used to be considered too difficult and were just put in palliative care now might actually be operated on. So you could actually have high risk patients as well, especially in some hospitals. They might have policies change. The classic calibration plot is just a scatter plot of predicted versus observed death rate or mortality rate, with the sample binned into deciles of predicted probability. So if you look at this one, if you go to the furthest right up the x-axis, this is the highest risk group, which is the 10% of the sample. Their predicted death rate is just above 10, but their observed death rate is below 10. Okay, and you can see that with the x equals y diagonal black line as well. So it just means that in this group, the model slightly over predicted their risk of death. Okay, because they haven't had as many observed deaths as we would expect for the number for the predictions. Okay, this difference is within confidence limits, and in my experience building these models, this is not a terribly poorly calibrated model. And in my experience running recalibration, this model is unlikely to benefit greatly. So I went with this model, and the overall calibration is not terrible. 59 deaths observed, 57.5 are predicted. So I'm saying at this point the overall model calibration is good enough, and we move forward with subgroup calibration. So what is subgroup calibration? It's just how well does the model, so calibration, I should have introduced as well. It's just does the actual risk that a patient is at, is that equal to their predicted risk? So if you take a whole bunch of patients with the same characteristics and the observed death rate is 10%, well, we would expect all these patients to have a predicted death rate of about 10% as well. Okay, and this might work quite well in the full model, but are there patients that there's bound to be patient subgroups when you've got hundreds of predictive variables? There's bound to be patient subgroups where the model's miscalibrated. Now the problem with this is, if you, let's say you had, because the data is mostly composed of neonates and infants and not many adolescents. So it's very possible that the model, just due to the underrepresentation of adolescents, doesn't predict the risk of death very well in adolescents. Now, if all hospitals have the same distribution of age in their patients, it's not really a problem because they're all sort of miscalibrated together, and they compare, the comparison is kind of washed out in a way. But if one of the hospitals has a disproportionate number of adolescent patients, they're kind of unfairly penalized in the benchmarking procedure. And in fact, if we did find a difference, if we did find a hospital with an increased mortality rate, the very first thing we would do is go back and say, is this the model's fault? Which it could very well be, because to some degree, subgroup miscalibration is unavoidable. It's mitigated. The best way to mitigate it is just to make comparisons among patients which are kind of similar. So it's kind of going back to stratification in the end. So we mostly look at within procedure benchmarking after risk adjustment, okay? Because a lot of the miscalibration will be between different procedural groups. Now, in this, if we look at this chart, we can see that cardiomyopathy actually has a observed over expected ratio of 2.5 times. What this means is that patients with cardiomyopathy are actually 2.5 times more likely to die than the model thinks that they are. Okay, so there's a potential here that if these patients, for some reason or another, end up at one hospital, the risk of death in patients at that hospital is being unfairly under predicted. So then the next thing to do, of course, is to check if if the distributions differ across hospitals. And this is the real data, but the hospitals are anonymized, and we can see that cardiomyopathy, like hospital C, stands to be unfairly penalized if this miscalibration is not taken into account. Okay, in reality, the prevalence of this condition is so low that it's probably not a big deal. But when we do the benchmarking, we'll definitely check if any of these things, if we think subgroup misclassification has a hand in any of the differences in comparison. Just finishing, so the final product looks like this. I couldn't show you the actual results, not even anonymized, because the confidence limits sort of give away which hospitals which. Obviously, Sydney and Melbourne are very large, Perth's much smaller. So once we're satisfied with the model, we undertake risk-adjusted benchmarking. So we just have a forest plot. You're observed over expected. If your confidence limits fall on the null value of 1, then you have a survival rate that's expected. The orange one is showing better survival than expected, and it gets a bit confusing because I'm talking about mortality and then the plot is survival, but we usually switch it around to show survival rates rather than mortality rates. Whereas the purple hospital has a lower survival than we would expect, even after risk adjustment. And this is where you would firstly check the model, then you would check the data, and then you might actually have to start discussions about, well, do we have to try to figure out what's going on at that hospital. Last slide. Limitations of the model. Lots of limitations of any model, especially this one. But the major limitation is the data sparsity, and that specifically relates to how we should model the risk conferred by hundreds of low prevalence predictors on a very low prevalence outcome. Okay, so the PRAISE-2 and the STS-CHSD mortality risk models dealt with this issue by grouping similar risk factors together. And so there's sort of that familiar grouping versus splitting dilemma, which pops up everywhere in statistics. We included all risk factors individually and left it for the machine learning model to perform variable selection, which XGBoost is good at doing. The problem was that 586 of the 677 risk factors were actually dropped from the model. So in many situations, this would be fine because those models just empirically aren't related to the outcome and not useful. But in our model, this means that many procedures and diagnoses were not included in the model, which brings coverage into question. So the model is supposed to predict the risk of mortality for all the patients, but how can it if, we have a patient whose procedures and diagnoses are not even included in the model? How can we really say that model relates to them? It might include other risk factors like age and weight and so on, but we're not sure of coverage. This was mitigated somewhat by including the stat categories. So every patient has a stat category, and that's informed by the procedure that they've had. So there is information on every procedure in there, just grouped like the PRAISE and the STS, CHS had to do. And the idea was the stat category will obviously confer some risk, and it did. It appears it has a SHAP value, so it was included in the model. And then we left it up to the model to decide if procedures within those SHAP categories had conferred like a greater or lesser risk compared to the stat category. And that's the end of the talk of 46 minutes. Any questions?
We have quite a long one in the chat from Alan, or Andrew, sorry. Andrew, if you'd like to speak to that, or Kim, can you see that in the chat?
I'm pretty slow with Teams. Let me get over. Okay.
Yeah, no, sorry, all good. I didn't realize we were enabled. So
yeah,
I start with a bit of a rant about ML evangelists and how they love to say, oh, just use ML, just throw ML at it. So the question is, in your sort of best estimate, how much time in this project was spent actually fitting the model to get an AUC value, and how much time was spent doing all the other stuff that you have to do in order to get this to a level to be clinically useful?
Yep, and on top of that, figuring out that something's wrong and going back to the start. Yeah, so gradient boosted tree is pretty easy to implement in R. So a lot of it is pulling it apart and seeing how it works. And then on top of that, it's testing it out, doing some benchmarking, finding some odd results, and trying to figure out what's going on as well. But hard to say, but obviously, yeah, I'd say a larger proportion of time in pulling the model apart and trying to understand how it works. And I totally agree with you. I think in some applications, it's fine to have a black box model, like serving advertisements to a customer on a website. If you hit the right customer, you can just evaluate that. Use the ML for some customers, not for others, and see how well sales are afterwards. But in medicine, I can't see how you can use a model like this without understanding it, and at least somewhat, and checking that it sort of makes sense. Because there's definitely the potential for it to pick up some really bizarre associations that no one would be happy with.
okay. Elliot has a question. Go ahead, Elliot.
Hi, thanks so much for the talk. This was great. How did you get your starting set of variables? Were those just what was in the registry, or did you do like a literature search or something to find those first?
That was, yeah, so that wasn't really so I played the role of statistician in this group. I'd say the procedure codes come from some classification index that I forget the name of it now. It's not the ICD-10, they have their own one, pediatric cardiac surgery. It's just standard. It's like the ICD-10 code of the pediatric cardiac world. The procedures and the diagnosis would just come out of that. The risk factors would have been basically a collection of non-cardiac malformations, which are either pretty common in cardiac malformations or are conceived to play a role, and then obvious and then easy to collect things like prematurity, weight, age, and stuff like that. So I can't say that It's not like there was a great deal of effort put into trying to identify the strongest risk factors. It was more like they used standard procedure diagnosis codes, and then comorbidities and additional risk factors that the surgeons and the hospitals believed were pretty important.
And there was no like aggregating of the diagnosis codes, I guess. Then, like, I know, like ICD codes, you can go to a few digits for specificity, and you can like group some for different comorbidities. But you just took the raw code as your feature.
Yes, we used all of them. So for that hypoplastic left heart syndrome, there's a number of different types of Fontan procedures which can be used. We use them all individually, and we included that stat category as kind of that stat category itself includes different, like lots of different procedures of similar risk. But we use all individual diagnosis, and that was obviously a bit of a dilemma. Was should we combine these or should we split them up? If I had more time, it'd be interesting to combine them as well. But that would put a lot of time on the surgeons as well, because they'd have to basically do it for me. Like I wouldn't be able to say these 10 procedures can be put into one category. But that would be interesting, but I'd need them to actually do it for me.
Fair. Yeah, but I imagine if you go that specific, you have a lot of very rare codes, especially since it's such a rare condition already.
Yeah, and most of the codes dropped right out of the model, and that was the question. Was so they're all included to some degree or another in those stat categories, but then they were on their own outside of that.
Interesting. Thanks.
And in talking with physicians, which type of representation of your data, which result would be most useful to them? We're doing something similar and trying to find the right kind of visualization that would be the most meaningful for clinicians. What have you found in presenting this kind of data?
They're pretty comfortable with SHAP values. They like when you pull out some of the trees in the GBT. And the ones I work with directly are pretty savvy. Like they know that SHAP values and all that. They're sort of they're our best guesses of what's going on inside the model. So I guess that the biggest problem is not misleading people. I'm not sure. I guess it's just it's kind of the stuff I presented, but it's being clear that this is not necessarily the most, like, explainability is only so good. Really.
And some of your factors or variables are modifiable and some are not. Like, do you ever do sort of that separation, or is it just looking at them as a whole and then seeing which ones really do the best at predicting, and then, the clinicians need to figure out then what to do about that?
Yeah, there's absolutely no. So this model was designed to be completely unrelated to any decision making. It was designed for two reasons. One was just benchmarking, and the other was, which it hasn't been used for yet, was just when the surgeon gives counseling to the parent obviously can't help but ask, what's the chances? And the surgeon didn't want to just sort of dig around in his head for a number anymore. He would like to say, we have this model, and it says your child's at an extremely low risk of the outcome, sort of thing. It's not about interventions or making decisions about patients in any way.
Okay. Does anyone else have questions or comments?
Well, I have one more if this time.
Go ahead.
I really like the XGBoost model personally, but I always you sort of get pushback from clinicians and the people on the more clinical side about the ML models versus the more classical statistical models like logistic regression. So have you just tested it to see if you have like a big improvement with XGBoost versus like just a plain logistic regression model to see if you really get some more juice out of it?
Yeah, so I compared it to the elastic net. So it's kind of like regularized logistic regression because there's hundreds of predictors. I wouldn't know how to go about building just a traditional logistic regression. But with that regularization, you can include all the predictors. And no, it's pretty, the AUC is pretty similar. The improvement in the gradient boosted tree is very minor. The main problem we had with regularized regression was just the list of the most important predictors according to the coefficient. The surgeons didn't like it. There was too many really rare conditions, and the results from the GBT seemed to make more sense for them. And then I would say to the clinicians as well, the problem with logistic regression is you kind of have to narrow down your group of risk factors, right, to a smaller group that the model, traditional logistic regression can handle. And if you don't want to do that, then you have to use regularization. And if you're going to do that, then you're interpreting coefficients that have had an arbitrary amount of shrinkage applied. So it's like, if you're happy interpreting that, that's good, but it's not necessarily, I don't know, it's not necessarily easy or straightforward to interpret either. But yeah, I'd like to know what you think about that.
Yeah, once you start applying the regularization terms, the coefficients are not as easy to interpret anymore. Yeah, and you'd really have to aggregate a whole bunch of these codes, I think, first to then do like the modeling expertise. So you get the modeling exercise again, so you could sort of get rid of a bunch of them in that way. Might be a tack, but it's hard to get like clinicians' time to actually whittle these things down, and that's what you would need to do that.
Yeah.
Unless there's case definitions out there that do something. Like I know there's a bunch for ICD codes that Hudo Kwan have, for example, done for in our group, but I've never heard of these pediatric ones before, so who knows?
Yeah, because I assumed they used ICD codes as well in the start, but I was wrong. They have their own more specific system of procedures and diagnoses as well. So I guess it's just a more expanded version of the ICD. And then, you know, even if you pin down one clinician to sort of group things for you, then you do that analysis with those groupings, and then the first question is from the other clinicians is, why do you group it like that? We don't agree with that. So you'd have to form like a full consensus and everything as well. So there's a lot of constraints. I think back to your question, I think I was a bit lucky in that these clinicians driving this were the opposite. They were extremely interested in machine learning and what it could do. And I was actually, it was kind of backwards a bit, because I was the one that was a bit more hesitant and sort of, what's really going on here? Because I was building something using for benchmarking. So I was a bit stressed of, what have I really done here to base these comparisons on? And they were pretty sort of happy that it was machine learning.
Well, that's great. Yeah, you don't have to find that, but I guess it's maybe more and more these days. No, really interesting stuff though. Thanks.
Thanks.
Yeah, I think we'll stop it there. We're almost at the hour, and I would like to thank everyone for coming and for Dr. Betts presenting to us. This is very relevant to some work that we've been doing, so very interesting to see your methods and how you've done it. Thank you so much, and this is being recorded and will be posted on the website of the Center for Health Informatics at the University of Calgary. So we will look forward to more talks from our international colleagues. And if anyone would like to present their work, please contact me or Francis and let us know. So thanks again,
Thanks,
Dr. Betts.
Thank you. Bye.
All right. Bye-bye.